Invite you for the first presentation. Presentation on topic long suprachoroidal tube shunt for surgical treatment of primary open-angle glaucoma and pseudo-exfoliative glaucomas. Nicholas Labauri, Tbilisi, Georgia. You're welcome.
Good evening, everyone. So great to see you. Thank you so much for the invitation. It's a great pleasure to me, and I congratulate that you are running very successful conference. I'm sorry for this long presentation heading here. So today I'm going to speak about the new suprachoroidal device. Actually, we are studying during the last few years, and I'll start about the glaucoma. We all know that the glaucoma is one of the main leading causes of the blindness. It's a very important disease to understand and treat. Especially, me as a retina guy, as a retina specialist in the retina department, it made me to do another fellowship in the anterior segment because many years ago, because in the retina department, we had a lot of patients with secondary glaucomas. So that's why, I'm practicing glaucoma the last 15 years now, and the shunt I'm going to introduce, it became after the many clinical trials of different devices, this idea, and then we could just made this dream true. So we know that we have the stepwise approach in glaucomas, like we start with a laser or the medications, and when this is not enough, we go to the incisional surgeries to plan the trabeculectomy or the tube shunts. And even the last 2 decades, the more and more popular is coming the mixed devices, and one of the parties, the suprachoroidal devices, which is much easier to put, much easier to place with the small incisions. It's a very quick procedure. However, it has to be noted that those, whatever is easy and quick to put, despite they are very expensive, they don't have the efficacy as high as we can reach with the trabeculectomy and with the tube shunt implants. And that's why mostly those implants are indicated for the mixed implants are indicated for the moderate and the mild glaucomas, or in cases of the combination when we are doing the cataract surgery. We know the importance of the suprachoroidal space, which was first discovered about more than 100 years ago by Heine and the colleagues. Before Heine, it was, I remember from the literature, it was Fuchs about in 1900s, that he just occasionally found that patient after the cyclodialysis, traumatic cyclodialysis, got the hypotony, and it was the idea that the suprachoroidal space could be the space which can be used for the aqueous drainage, and then became popular many different kind of surgical procedures. But the philosophy behind those surgical procedures were to create the cyclodialysis cleft to connect the anterior chamber with the suprachoroidal space. And we know that the suprachoroidal space, in the suprachoroidal space, there is a negative pressure. And the farther we go towards the optic nerve into the suprachoroidal space, the more the negative pressure is increasing. So the difference between the anterior chamber pressure and the suprachoroidal space is increasing. So this is many different kinds of implants suggested so far. Some of them, they are just history because it was withdrawn from the trials or clinical practice because of the complications. Now, very few of them, they stay in the market and they're still used. And some of them is just under the trials. This is how looks our new device, which is made by silicone tube, and also we add the silicone belt, which it is used to limit. It's called limiter to prevent the migration of the shunt into the anterior chamber, and also on the distal end it has the PMMA parts, the PMMA cylinder to facilitate the implantation and insertion of this tube into the suprachoroidal space. So it has all the same sizes like a Berwald or Ahmed tube, internal diameter 0.33, a little bit more, and outer is 0.6. So this is a retrospective longitudinal study because we couldn't do it prospectively. Prospectively, I operated so far more than 200 cases, but we recalled the patients, and 66 appeared within 2 weeks. After the 3 years, we started the surgeries, and those patients were observed with a different kind of measurements, such as the IOP, which is very important, CD ratios, visual acuities, etc. Our primary outcome measures and primary success was defined as reducing from the baseline, reducing at least 20% of the IOP. And when the IOP was between 5 and 21 millimeters of hydrargyrum. And the success was divided in two different kinds. It was a complete success when there was a 20% reduction, at least when the pressure was less than 21, and when the patient didn't require any drops. But the qualified success was the same, everything, but when this eye was still requiring 1, 2, or 3 different class of eye drops. That's why the success was divided into complete and the qualified. A failure was everything, but whatever I just mentioned, it was less than 20% reduction, more than 21 IOP. Those patients considered as the failures. So here I will go very quickly through the procedure. What we are doing here, the implant I already discussed. So here I'm implanting this in the infratemporal quadrant, but the last time I'm doing this in the supratemporal quadrants. As you see, we are just opening the conjunctiva and creating the partial thickness scleral flap, which is 4 millimeters in thickness and the 7 millimeters in length. This is a combination with the phaco surgeries. This phaco part is not important here, but once we accomplish the IOL, the phaco with IOL implantation, you see that just the same as we do in the tube shunt procedures. I'm entering into the anterior chamber and using the round crescent knife to explore the suprachoroidal space. I'm just injecting a little bit cohesive viscoelastic to facilitate the insertion of the tube itself. You see the implant is coming here, and it has a limiter over here. I will use 0, the limiter here. It will go up to this point. So once the distal end is already placed into the suprachoroidal space, then the proximal end is inserted into the anterior chamber, the same like we do in cases of Ahmed or Perwold devices, and it goes down until the limiter sits onto the sclera. This is a fixation suture which I'm using anymore. I don't use anymore, and I use a vicryl sutures to close the flap and the conjunctiva. However, if you have the glue, then all this procedure can be done without any sutures. So this is pretty much the surgery here, and the tube here is in the anterior chamber. And the next slide shows after several months how it looks as the same patient, how it looks on the slit lamp, and you see here we have the tube into the anterior chamber. Here is a flap, and you see the intrascleral part of the device here, which dives here into the suprachoroidal space, which is this point, and goes under the sclera and above the choroid, which is suprachoroidal. And this is how it looks on the UBM on the right side and in the anterior chamber. So even this is different patient, but this tube is so long that reaches about the latitude of the vortex veins, and you can see the anterior, the intracameral part of the shunt itself, and the suprachoroidal part. You can see some notch here. You can see how it is placed here. And however, it doesn't have, oh my God, I just jumped it. It doesn't have the bleb, of course. It's a bleb-less procedures. I forgot to tell you that this is completely implanted into the scleral wall and then under the sclera into the suprachoroidal space. And it's a bleb-less procedure. So that's why it is called the BUCS procedure instead of MIX. So here is some results I wanted to highlight, and this was a preoperative baseline IOPs. Here is depicted is a mean standard deviation Here is a 27 plus minus 5. It was before the surgery, and this is what was the mean follow-up period. It's about 19 months. The minimum was 4 months, and the maximum was up to 4 years. And CD ratios and visual acuities are depicted here. So as a result, here is a baseline you see, and it's divided in combined cases when we combined the shunt with the cataract, and in standalone, it was 17 eyes and 49 eyes were just combined cases. And you see what was before the pressure and after. So it was about more than 50% of reduction of the intraocular pressure. So it was 27, let's say, plus minus 5, and it's 13 plus minus 3. And another group is 28 plus minus 5 and 12 plus minus 3. And it's about, let's say, the 2 years of follow-up. So this is a number of the drops, and number of the drops also reduced. So it was before the surgery, so about 3 drops, 3 different groups, and reduced down to 2 or 1.5. Here is that we achieved the percentages of these patients, how many of them achieved higher teens and lower teens. And it appears that these implants actually gives us the higher teens instead of lower teens. Okay, that's why mostly patient has advanced glaucoma, and our target pressure is 10 or 12. Probably those implants are not so good. But if it's moderate or mild glaucomas and the excavation is not so high, then it could be a proper procedure. The other advantage of this procedure is that in case if the shunt fails, because as we know, the fibrosis always appears from the distal part, and also it has some slit cuts over here, and slit cuts usually theoretically we don't see it, but theoretically we assume that it works when the main lumen is clogged by the fibrous tissue over the time, and sooner or later everything fails, as it's said in glaucoma, and of course the suprachoroidal shunt will fail as well. We have 1 more year observation now. We will be publishing soon, which is a 3rd year the follow-up. And in case if it fails, the same scleral flap can be used to open the same scleral flap, same quadrant. Same quadrant can be used to put the Berwell shunt or Ahmed valve, and same scleral tunnel can be used to introduce the tube into the anterior chamber. So that's why now I'm doing all these procedures on the supratemporal quadrants. So here it's just comparison of different devices. And I have to say one thing, that it's called long suprachoroidal shunt because the length is 15 millimeters. So no one else has tried such a long shunt. And what made us to do the long shunt, because we know that farther we go to the deeper we go to the suprachoroidal space, we have less and less higher and higher pressure gradient. So we have higher negative pressures. That's why the drainage is improved and efficacy probably is improved. And to compare to the SIPAS, for example, or the Miniject, they had let's say almost 40% of IOP reduction in 2 years and to compare to our results, which is more than 50% of the IOP reduction in 2 years. So other advantage is the placement itself. So the SIPAS, we know that was withdrawn from the market because it was damaging the endothelial cells, because it is placed across the posterior scleral spar. You have to tear the posterior scleral spar and insert it into the suprachoroidal space. But in opposite of this, the tube shunt which we are implanting, so we are bypassing the scleral spars. That's why we don't have complications, a lot of complications such as the hemorrhages, and we don't have unpredictable IOP reduction, and also the angulation of our tube is more angled. That's why it does not irritate the endothelial cells as much as could do the SIPAS or the Miniject or any kind of mixed suprachoroidal implants. And as I already mentioned, so we achieved about the 40% medication reduction, about more than 50% of the IOP reduction at the 2 years. And actually, this implant has showed a lot of advantages. These results led us to make the publication in European Journal, just published recently in 2025. All the details are given in this publication. With this, I would like to finish my presentation and thank you so much for your attention. It was my pleasure again to participate in your wonderful meeting. If any questions, I would love to.
Thank you, dear Nicholas, for the excellent presentation. And I have two questions. The first is, you showed the successful experience after surgery of primary open-angle glaucoma and exfoliative, but is comparable results? We know that pseudo-exfoliative glaucoma is the difficult in management as conservative as by surgical procedure. How do you think this tube has differences in results in efficacy in these two types of glaucoma?
Actually, okay, so the 66 size were not the big enough to distinguish between these two different scenarios. Because as you know, I don't know about the Ukraine, but in Georgia we are living in endemic zone because every second patient, every second glaucoma is exfoliative glaucomas, and most of these patients, I'm giving the results here. The most vast majority of them, they were having the exfoliating glaucomas. Very few of them, they were having the primary open angles. That's why it's very difficult to me to answer this question, because there was no chance to compare them in one-to-one fashion. So because in vast majority, it's pseudo-exfoliation glaucomas in these cases.
Thank you. And the second one, I know, Nicholas, that you are not only surgeon of glaucoma and cataract, you are vitreoretinal surgeon, and you manage the very difficult post-traumatic pathology. How do you think this device for the IOP normalization is possible option for the treatment of post-traumatic glaucoma?
Okay, so post-traumatic glaucoma is one of the most difficult scenarios. Probably I would not advise this device in aggressive glaucoma, such as post-traumatic or neovascular types of glaucomas. In cases if it is a post-traumatic glaucoma, it depends what is the mechanism of the glaucoma. If we have the extensive anterior synechias followed by the ciliary body clefts, which happens within 1 year, or we have some other kind of, the synechias into the anterior chamber, then probably I would think about the episcleral tube shunts instead of suprachoroidal shunts. So this is not a very powerful device. So just what I'm trying to explain is that this is a device which by its efficacy and duration could be better than the mixed devices, but it is not more in terms of the IOP reduction and the durability, but it cannot be more powerful than the trabeculectomy or the episcleral tube shunts like the Berbel shunt, let's say. That's why, as I already mentioned, the best scenario to be considered this shunt, it would be the mild or moderate cases, which is refractory of the medications. In those cases, I had plenty of cases with 35, 40 IOPs, and after the implantation, so these IOPs are coming below the 21, but very few of them are reaching the 10 or single digit, okay, or 12. Some of them they reached, but most of them they require the drops also. And my impression is that I'm not sure. I don't have 5 years of results, but I think that sooner or later they will fail. And the best is when you use these implants in high age. So higher is the age, the better it works. Lower is the age, because the fibrosis is the main enemy of these implants. And not aggressive glaucomas. I have tried in neovascular glaucoma, just one case, and I saw the results. I just gave up because it's obvious that it's not going to work. And we don't exactly know in neovascular glaucomas what's happening in the suprachoroidal space as well. But actually, it was not efficient. So the patient still requires a big tube shunts. And that's why I just stopped using or trying this kind of implants in such glaucomas. But however, I have used it in the narrow angle glaucomas, and it's sufficient. And also, if it is combined with the cataract, then in the long run, this performs much better than in phakic patients. That's why nowadays I always consider to do the shunt with the phaco, or just if the patient's already pseudophakics is the best scenario.
Thank you, Nicholas, for the presentation, for the comments, and we absolutely agree with you that for the post-traumatic glaucomas, more efficient episcleral shunts or valves or other devices. Thank you again for your active participations in our conference, and see you next time. Bye-bye. Bye.
Goodbye. Thank you so much. With love and respect. Bye-bye.
Okay, and we move through our session, and the next our presenter we can see Dr. Bekir Sidki Aslan, the head of eye department at Memorial Hospital Ankara, Turkey, with the presentation femtosecond laser in cataract surgery. Good afternoon. Nice to meet you, dear Dr. Bekir.
Very nice to meet you. I'm delighted to be with you. It's my honor to be invited and speak at this most prestigious meeting. Thank you very much for asking me to give a lecture on this topic. This topic is something that really seems to be struggling nowadays. And I think I will be able to share with you my insight about this topic. So, can I start?
Yes, you are welcome.
Okay, thank you. I just want to share my desktop. Share my desktop. Excuse me. Okay. Just a moment, please. Yeah, here we are. Okay. I think I will just make it. Now, I'll start my talk with the concepts for FLACS, femtolaser assisted cataract surgery, and I have no financial interest with this topic. And the picture that is here is Tibor Juhas, the inventor of femtolaser, who kindly spent, as we established our femtolaser in Ankara, he kindly spent 3 weeks with us so that I could learn from the first hand how I could proceed with the femtolaser. So I'm just going to tell you about a few words about femtolasers. As you know, femtolaser is very fast laser, and it has very precise action on the tissues, and it avoids using high ultrasound energy, and apparently improved outcomes are all available in the literature. Customized treatment are not an option, but you can treat every patient in a customized way simply with the picture of a real-time OCT. If you compare these two techniques, standard manual cataract surgery and femtolaser cataract surgery, apparently laser cataracts are very precise with incisions. Capsulotomy is perfect and round circular, and you can put it anywhere on the capsular bag, and you can have it with any size. That is a very, very advantageous position. And if you can fragment the lens, and that makes the lens soft so that you can aspirate hard nuclear materials with an easier way. And apparently, once the cataract is softened, you use less ultrasound energy. You can tailor your surgery using the real-time OCT and potentially more accurate in the placement and astigmatism correction. Lens placement is, of course, very crucial, as you know. And if you don't have an overlapping capsule, that may cause a tilted lens, which may end up with unwanted images. So when you compare these two, these are the highlights that I can make for femtolaser, whereas otherwise manual surgery and femtolaser cataract surgery are almost identical. Well, once you look at this slide, you see that when we are dealing with a premium lens, or when we are going to deal with the real astigmatism around 1.25, or against real astigmatism around 0.75, then you are going to use flax for sure. If you want maximum precision with your surgery, if you are happy to pay the added cost, then flax is the mainstay of surgery. And of course, your surgeon, once recommends it, he knows that he will be able to do specific points on the eye anatomy. So I used LensX laser, and my laser was established in 2013. And you see 3 screens. The screen on the very right of myself is the screen for the femtolaser. The one in the middle is for variant digital navigation. And the one on the left is for the assistant to adjust the parameters in case I make a change. And apparently this tool can make also LASIK flaps. That is an added bonus. Globally, 3,000 eye surgeons were asked, and 1,000 in the United States, what the name should be. The acronyms are as RELAX, FLAX, FALX. I don't know which is the best one. I rather prefer using FLAX. And this femtolaser energy just delivered to the tissues, just separates the tissues, and it makes us possible to manipulate all the tissues starting from the cornea to the cataractous lens. And we have one laser, 3 different tissues. How we overcome this discrepancy? We change the size of the pulse of the laser. For the cornea, the bigger size. For the capsule, we use medium-sized laser beam. And for the densities of cataract, we use the smallest size beam. That enables us to make what we want, to make cataract surgery a proper one. This is the way it works. It is very, very fast, and it just separates the tissues, but it doesn't touch to each other, but they just coincide after you put the beam on one point. The first and the second beam just gets in touch with the energy that is dispersed in the tissues. Well, in an ESCR study, it was found that 98% of the lasers, femtolaser, were used for capsulotomy, and for 90%, laser was used for nuclear fragmentation. Only 30% of the cases, they used laser for incisions and other purposes. The mainstay of this femtolaser surgery is capsulorhexis. Once you get a capsulorhexis with the femtolaser, the higher order aberrations are less. Lens dislocation and lens tilt is highly unlikely. Edge dysphotopsias may diminish. And now literature is appearing as the posterior capsule pacification is less with the capsulorhexis than when you make it with the femtolaser. And you can center the lens depending on the visual axis. And apparently you know that the visual axis is closer to the temporal side. And you can put your capsulorhexis location depending on where the visual axis is. And you can make this happen with the variant tool that shows you where to put these laser beams. Here is the patient interface. And this laser soft fit is somehow very useful to deliver the energy, but there is one discrepancy with this one. You can use it with the corneal powers from 41 to 46. And when you look at this picture, the outer side corneal powers are not the good candidates for patient interface. That means that the docking with this laser soft fit interface cannot be perfect with the bigger corneal powers or smaller corneal powers. Excuse me. The anterior chamber depth is also another crucial criteria to apply this patient interface. When you have shallow anterior chamber, there's a difficulty in docking, and there's a risk of laser hitting the cornea and iris, and apparently you can have some suction loss. With the normal and the deeper AC anterior chamber depths, you can make a better approach with this femtolaser. Well, there are always a question, does flax has an impact on the retina? Yes, if you apply the docking device, there will be a transient intraocular pressure elevation, and especially in glaucomatous patients and patients with the retinal vascular problems, they may be in trouble with this pressure rise. So you must be very careful with high-risk patients, and they need extra caution. Posterior vitreous detachment is also an indicator for the safe retina. When the vitreous detachment occurs, it may cause some traction on the retina, and flax may accelerate this posterior vitreous detachment, especially in older patients, higher myopic eyes with long axial length. And sometimes this can lead to retinal tears and increasing number of floaters. And sometimes, surprisingly, cystoid macular edema is something that we encounter. Inflammatory mediators are not rare. We see it very frequently with the manually made cataract surgery. But in this case, despite the capsulotomy precision and the less energy application benefits, laser application may still affect anterior chamber inflammation, and we must get prepared to get a cystoid macular edema once the blood-retinal barrier is destroyed. Well, this is a case with excellent docking, with no lens tilt. The capsule is perfectly located, and this is well-centered docking. And with this one, the docking is not perfect. As you see, the capsule is somehow distorted. So you have to be aware that anterior and posterior delta ups and downs should be carefully placed here. With the lens tilt, of course, the safety margins now make a big difference, and you must take care of the posterior anterior capsules once there is an improper docking. So now we have to learn a lot of parameters for capsulotomy, namely the size of the capsulotomy, where you start your energy until where you apply your energy level, and the spots separations, layer separations, or other items that we have to consider with the capsulotomy and with the fragmentation, and of course with the incision. You can make any size, any type of incision with this laser. It's not an issue, provided that you prepare your numbers, parameters properly. And of course, you can have also side port incisions, but they are used very rarely nowadays. Arcuate incisions pattern is also crucial. We have here a bunch of information to make this happen so that you can correct the astigmatism with the laser. There's Tampere rule. You have to adjust energies and spot separations. And if you bring this energy and spot separation down, then the cut quality will be excellent. There's a Tampere rule when you're using femtolaser. Of course, femto laser is not used alone. We have Varion unit where we measure the patient, we evaluate what the patient needs, and with this Varion information, we upload it to the laser, and the laser does everything that Varion dictates to the machine. Here is a view of the patient. Now the patient is put under the laser. I'm at the back of the area. We have 3 screens. We are first look at the Varion screen and then the laser screen and adjust what the patient needs and customize the patient's needs accordingly. Here is how we do the docking. Docking is not a simple task. You have to be very careful about locating this patient interface at the right place. When you put your docking tool, soft patient interface, you have this kind of picture where this picture can be okay. As you see here, I am playing with the format of the treatment after the Varion shows me what to do. And I can put anywhere these incisions, anywhere any kind of change could be possible. And of course, this the area where we put this laser beam is critical. As you see, we always keep a safe area in the front and at the back of the lens with the real-time OCT. And now we are executing the capsulorhexis, and we are able to follow here when the application is over. As you see, it shows me in this diagram, then relaxing incisions, and finally the main incision is carried out. Now, just look here how we can remove the capsule, free-floating capsule, without any trouble. In case there are breaths, you can continue as if you are doing a manual capsulorhexis, and it will not cause any harm to the tissues. Now, it's a real-time cataract surgery with no fast motions. The central area is removed first. This kind of surgery was first done by us manually, and we published this in 2012 in Journal of Cataract Surgery. This kind of application, removing a central crater, 3 millimeters, and then dividing these pieces into many pieces. You can do it as many as you want. You can apply it on the laser. And then if you see how smoothly the nuclear pieces are coming towards the tip. And this is a +3 lens, which looks as if it is, well, +1 or perhaps +2, that's all. And you just remove every bits and pieces. That is the real time. And if you look here, the cumulative dissipated energy is 6.39, which is magnificent. Now, does flux come with better refractive outcomes? I don't know. Their peer review studies show that they are not superior to manuals, but I'm sure that flux cases hit the refractive target more in my cases. And especially higher order aberrations are far more less when I operate with femto laser. Correction of astigmatism is crucial nowadays, and patients are very eager to have this option. And the precision of depth of the incision with laser is what we can achieve. And when the flux is combined with the best methods, choosing the toric magnitude and alignment, Really, the results are phenomenal. Capsulorhexis integrity is somehow identical with manual and flex. Of course, you have some capsular issues, but that's not higher than that we get it with the manual. We had some subluxated cataracts, so something like 12 cases, and we adjust the position of the capsulorhexis, and the results after 10 eyes, after 2 months, were really very, very impressive. So we had the extracapsular surgery. It was predictable and safe. We had phacoemulsification, less astigmatism is added, and we have now flax. It's safe, fast recovery, and it's indeed a robotic surgery that enables us to make the incisions, capsulorhexis, fragmentation, and definitely full astigmatism control. Well, there are some drawbacks. Case time increased. I'm not sure about this, but some people say so. Capsulorhexis margins are not strong. I agree with you, especially if you're going to deal with the capsulorhexis margins with the subluxated cataracts, beware of this discrepancy. Meiosis may occur if you wait too long after the dilatation, and corneal incision integrity may not be solid as it should be, and apparently the expenses are not that much. So we have the discrepancies, but we have more precise capsulotomy. We definitely have lower CDs. Postoperative central corneal thickness is apparently, definitely far more superior than manuals. And reduction in corneal endothelial cellulose is really phenomenal. We get only 3%, maximum 3% of endothelial cellulose, and similar overall complications rates with the manual ones. And I very, very rarely see vitreous issues. So there is a saying by American Academy president, transitioning from a volume-based system to a value-based one is the future of ophthalmology, which I admire and take this term very seriously and apply it to my surgery practice. I definitely believe that newer technologies contribute outstanding efficiency to the crucial steps of cataract surgery. Thank you so much.
Thank you, dear Dr. Bekir. Very interesting presentation, and we have some questions. The first is, sometimes we need to perform the combined surgery, cataract and glaucoma. From your experience, or what is your opinion about possibility to use femtolaser-assisted cataract surgery in combination with the glaucoma surgery, and which type of glaucoma surgery in this situation would you prefer?
Well, thank you very much. I like this question very much because the femtolaser is a surgery that is less traumatic. You can open the capsule, you can fragment the nucleus, as I told you, before you open the eye, and apparently you can continue with your glaucoma surgery first, and then you get into the eye easily with a ready, perfect capsulorhexis and a softened nucleus. So it really helps to operate with glaucoma combined. That is really, it gives us an outstanding result. I strongly recommend, if you have the option to use femtolaser, use it with for glaucoma cases. It really gives us really outstanding results, and it's more productive than manual surgery in my cases. Provided that there's one exclusion, the pupil is dilated more than 5 millimeters. If pupil is smaller than 5 millimeters, it may not be so easy to apply femtolaser. Yeah.
Thank you. And the second one, what percent of cataract surgery in your clinic is performed with femtolaser assistance?
Well, in my clinic, 70% of my cases are femtolaser cataracts. 30% is the cases with the smaller pupils, and for the ones who cannot afford the added cost that we ask for femtolaser. Otherwise, we nearly always recommend our patients to get this laser surgery since the results are less traumatic than manual surgery for sure. Yeah.
Thank you. Thank you so much for your active participation, for your presentation. See you next time. Thank you.
Thank you very much for inviting me, and take our greetings from Ankara. Thank you.
Thank you. Goodbye.
Bye-bye.
So I would like to introduce our next speaker. It's Professor Barbara Parolini from Brescia, Italy, with a presentation about myopic traction maculopathy, staging and customized treatment. Barbara, we're glad to see you.
Hello.
Hello.
Thank you. Thank you so much. I'm so happy and very honored to be with you today. Thank you so much. I will start and then I will be available, of course, for your questions, not to waste any of your time. So today I will speak about myopic traction maculopathy and the treatment with macular buckle. Myopic traction maculopathy, as it is known now, it was published and defined 20 years ago. I was working with Giacomo Panozzo, and I definitely regret I was not part of this publication. It is not a niche problem because myopia is growing and it is expected to hit 50% of the population in 2050. High myopia is part of it, and it involves 20% of this patient, but pathologic myopia is 3%, and MTM is 30% of pathologic myopic cases. At least this is what literature says. So roughly about 75 or more million of people in the world. Looking through the magnetic resonance, we can see immediately the difference between a metropic and pathologic myopic eye, which are longer. And the axial length is at the base of all the problems. So we are not speaking about an eye made like this, but an eye with a staphyloma. So it is not just the long axial length, but the irregular elongation of the eye into this ectasia that creates the myopic maculopathy. And these are different high myopic eye depicted with the MRI. So you can see that you can have uniformly large and long eyes or eyes with the staphyloma, which can be located in the macula or in the papilla. It was studied that these eyes keep elongating for all their life. See, in the red square, you can see a person that at 42 years of age had an axial length of 32.9. The same person at 68 years of age had an axial length of 33.3 eyes. And this is a group of eyes that was followed for more than 20 years. All of them showed a progressive elongation. So this is a disease that does not stop. And if this is a wide field OCT of a normal, let's say not a metropic eye, this is an OCT with high myopia. You can see the thinning in the choroid is the main feature that you can immediately spot. And this is an eye with a double staphyloma on the papilla and on the macula, and this is a pathologic myopic eye. So staphylomas were classified into different types, 10 according to Curtin and 5 regrouped in according to Kyoko no Matsui. The one that we care the most are the type 1 involving macula and papilla, or type 2 involving mostly the macula, or type 3 involving the papilla with the macula on the slope. The inferior staphyloma or the nasal staphyloma are very, impressive to see. Some of them may lead to myopic traction maculopathy, but mostly it's type 1 and type 2, as you see here. So myopic maculopathy is the, let's say, altogether, these features, the atrophy, traction, and neovascularization describe myopic maculopathy. But today we will focus on the tractional part. The entity of atrophy basically tells us how much the patient can see and will see after treatment. So let's focus on traction. How do we diagnose the traction? While we can very well see the atrophy through the color, for the traction, we definitely need the OCT. This is the main exam that tells you all the details, because sometimes you can suspect, but in this case, for example, you can think about only atrophy, but in OCT, you can see the schisis. Again, here, it seems almost normal, but with the OCT, we can see the schisis, and this is another example. So there is always a discrepancy between color and OCT. So very important to do the OCT to all high myopic patients. And it is very important when available to do the wide field, because look at this patient. This is the 12 millimeter OCT. This is the same patient with the 23 millimeter scan, and the same patient with the 26 millimeter scan, because the wider the OCT, also the deeper is the scan that can depict the staphyloma. And you can see here the OCT superimposed magnetic resonance. So how does MTM form? I defined the pathogenesis, the game of forces, because if we put together the eyeball, the retina, and the vitreous, in the normal situation, when nothing happens, when we have no traction, we have one centripetal force aiming to the fovea, which is mainly held together due to the Mueller cells, the external and the internal limiting membrane. But against this single force, which is centripetal, we have many centrifugal forces playing against. And the forces which are perpendicular to the fovea will induce the schisis and the detachment of the retina. The forces tangential to the fovea will induce the splitting, which is the holes. For example, here you can see an anteroposterior traction perpendicular to the macular plane, and we have a detachment. Actually, I don't call this retinal detachment, but scleral detachment, because, as I said, it is the sclera and the elongation causing all the problems. However, of course, we know that the vitreous can act itself, creating anteroposterior traction, but you will see the main culprit is always the scleral elongation. If the tangential force is preeminent, we will have macular holes. And if the forces are combined, we can have detachment with holes. So it's a game of forces. So this is the same eye that might grow and grow and grow, a long life, developing initial schisis and then detachment. I have studied hundreds of eyes along the past 15 years, and I could recreate the natural history, the evolution of MTM, and I have seen that it cannot be divided in types, but in stages, because it is an evolving disease. So this table is what tells you, it tells you everything about MTM, everything you need to know. the nomenclature, the evolution from stage 1 to 2 to 3 to 4, and A, B, and C. Stage 1 is the initial schisis in the inner outer layer. In stage 2, the schisis deepens into the outer layers. In stage 3, you have a mix of schisis and detachment. And in stage 4, you have just detachment. If you notice the retina here, there is no schisis because the retina is totally detached. For each one of these 4 stages, please look at the inner fovea. You can see that here the fovea is intact, while in stage B, there is a lamellar macular hole, and in stage C, there is a full thickness macular hole. So in summary, if you want to define MTM, you look at the macula and select 1, 2, 3, or 4. Then you look at the inner fovea and select A, B, or C. These are just some examples. You look at this OCT, you look at the macula, you see some schisis in the inner layer, so it is stage 1. You look at the fovea and it is intact, so this is stage 1A. This will be stage 4A. This will be stage 3B, so on and so forth. And this was published 5 years ago and then validated by an international panel of colleagues. So let's switch now to treatment. Should we treat MTM? When and how? Well, considering that the main problem, as I said, is the progressive elongation until the retina detaches because it cannot follow the excessive elongation of the sclera, what does make more sense? To push and elongate the retina from the inside, or to push and shorten the sclera from the outside? Let's see what history said. Well, everything started by shortening the eye, either with the scleral reinforcement or in 1957 with the initial examples of macular buckle. But this procedure was abandoned when vitrectomy arrived because it was considered difficult. And then when we had vitrectomy, we tried to solve all the problems with vitrectomy. The point is that vitrectomy was not so successful because this is just an example. You see that vitrectomy for MTM leads you to 80% anatomical success, but only in the easy initial cases. If you have advanced cases, there is anatomical failure. I think you experienced this problem. Because with vitrectomy, you can have a high rate of relapse of macular detachment, reoperation, iatrogenic full thickness macular hole, and silicone oil that inevitably leads to glaucoma in these eyes. So then the literature tells you that there was a back and forth from macular buckle to vitrectomy, buckle to vitrectomy. I published, for the first time, I presented the buckle in 2009, and then I went more and more on with my publication because I want sure that the buckle was the right thing to do. And now that I have 16 years of data, I even more confident that this is the right way to go. Because everybody tells me you can do it even with vitrectomy, but if you have cases like this that do not have a staphyloma, well, you can be successful with vitrectomy. But if you have a deep staphyloma involving the macula, there is no way. If you try to attach this retina, definitely you will create a macular hole. It's inevitable, or even in a case like this, or in a case like this. In fact, this patient was operated with vitrectomy, and this was the end of it because the retina is attached, but the patient cannot see because of the atrophia. So these are only some of my publication, and in this one, I have proposed a customized treatment. So this is the same table, but in red, I have added what I think is the right thing to do per case. So in summary, I think that stages 2, 3, and 4 now should be treated with the macular buckle, and you should reserve vitrectomy only to close a macular hole. So stage 1C, which is basically only just the macular hole, you can do vitrectomy and be successful. But if you have schisis and detachment, do a macular buckle. And then if you want to close the hole, you will add vitrectomy for the hole. So macular MTM should be treated. The hole needs definitely something on the fovea from the inside, but schisis and detachment need a macular buckle. And why should I say it should be treated? Because all my colleagues always tells me sometimes MTM spontaneously improve. So why do you treat it? I have observed that spontaneous improvement is only temporary. It is due to temporary vitreous relief, but then MTM will restart because of the progression of the staphyloma. Look at this example. This is 2017, September. There is a schisis that switches from stage 3 to stage 4 in 2 months. And then it seems to relieve, to be spontaneously improved. But a few months later, it starts again. And this is another example. See this patient from 2017, 2018. It detaches in June 2019. And here it seems to improve 1 year later, but then it starts again 1 year later. So you just have to be patient and follow these patients. Here, another example, there is an improvement in the second line here, but then it starts again 2 years later. And I have so many examples. Look at this patient. In 2010, he has a detachment, and then in 2011, he has an improvement, and even better in 2013, 3 years later, but then it starts again, and this is 4 years later. So we need to follow this patient for a very long time. So I have very important things to tell you. Look at this patient. She had an MTM in stage 3. It was 2010 and she received vitrectomy. She had a new macular detachment and she received vitrectomy with silicone oil, and she has a success. This is August 2010. And the oil was removed 1 year later. Sorry, let me go back. And she was fine for 4 years. So every colleague would have told me vitrectomy works. But then if you wait long enough, it starts again 1 year later. So she was initially observed and she seemed to improve, but then it started again and again, and worse and worse. She received just more vitrectomies and she had a very sad outcome because she came to me with a full detachment under silicone oil. I did a macular buckle and finally she was fine. And look at this patient. On the top, she had a detachment. She received a vitrectomy and she ended in a full thickness macular hole. And I've just seen her 10 years later, the detachment restarted. She definitely, believe me, they need a macular buckle. So this is everything you need to remember from my talk. A macular hole in MTM needs vitrectomy and ILM flap, while the schisis and detachment need a macular buckle. So with the flap, as you can see here, you can definitely treat the macular hole. It is not easy because it is very difficult to see inside the myopic eyes. And the intraoperative OCT is very helpful in these cases. Let me move forward to the end of the, okay. But definitely you need the buckle to treat the schisis and the detachment. And this is the buckle that I started to use in 2000, that I published actually initially. And I modified it to make it smaller and smaller. But since it was an off-label model, nobody was using it. So I switched to this company, AJL. They are based in Spain. They were making this buckle that I didn't like at all. And I modified the design. And this is what I'm using now. So this is the macular buckle that I am using since the last 4 years. I created these 4 holes, which makes it easier to insert and to suture. And I am now making a very small head, much thinner, in order to create a very nice final shape of the macula. And this is a loading device that is very useful to insert the buckle, to suture the buckle, and to check the final position. So these are the two connected together, also with the light to use trans illumination. So in summary, the surgical technique consists in opening the temporal conjunctiva, isolating the superior and temporal rectus muscle, marking where you want to place the suture. I will tell you why. I will tell you how you can place one suture and then prepare the macular buckle with the loading device. And you just have to insert the macular buckle in the superotemporal quadrant like this. And then with the suture through the hole, you fix the position of the buckle. But the most important step of the surgery is to confirm the location, like as I'm doing now through a lens, a contact lens on the cornea. You can see the procedure from the lateral view. So the nurse can help you tilting the eye toward the nose and you insert into the superotemporal quadrant. And this is a combined surgery. I have inserted here the macular buckle, and I will move forward. I was doing live surgery here. So after inserting the buckle and suturing the buckle, you have, let's say, a shortened eye, and at that point, you can place the contact lens and do the peeling if you need to close the macular hole. I have an intraoperative OCT, which is very useful, but you can also do it without the intraoperative OCT. So I had done a preliminary study to find the correlation between the axial length that you see in the yellow column and in red, the distance from the limbus where to place the suture. But this was using always the same buckle, which was 23.5 millimeter long. So in the end, I have asked the company to make 3 sizes of the buckle, small, medium, and long, in order to be able to suture it always around 12 millimeter from the limbus. So it will be much easier to suture at that distance. And in the end, I want to present you some results of my case series that I started to collect in 2008. And they are published now. I published last year just a case series on the new macular buckle, but this year I published my entire case series on 206 eyes for which I had 16 years of follow-up. And the anatomical result is very impressive, not only, but they improve a lot of vision. This is the message I want to give you. All my colleagues think that these are not patients that can see well. Instead, they do. If they don't have atrophy, they can see very well. This patient can see 20/30 and she has no scotoma. Also, this patient 20/50, they can read. These are just the pre and post example to show you how much they can read. So this patient was treated with 5 vitrectomies and she lost the vision. She came for the other eye with this condition. I just applied the macular buckle and she can see 20/25. So these are the results. See, big and narrow staphylomas, just one surgery, macular buckle, vitrectomy, ILM flap and gas, and after 2 years she can see 20/50. And this is very interesting. The same patient in 2 eyes, he had the same situation. In one eye he received the buckle and in the other he received vitrectomy, and you can see the outcome. In one eye he is attached and in the other he has a iatrogenic macular hole. It's always like that. So I did the buckle and now he can see in both eyes. Colleagues always ask me, how is the eye after the buckle? So on your left, you can see a white eye, completely normal after macular buckle. In the other eye, a red eye under treatment for glaucoma and multiple surgeries. And these are the complications that I have now, some elevation deficit and diplopia. I will try to make the buckle smaller and smaller to avoid this, but I think it's totally acceptable. So there are no visual field defect. This is how it looks at magnetic resonance. And most of all, there is no atrophy. So the atrophy that you see in evolving in these eyes is the natural history of myopic maculopathy. I have made a study collecting data on my patient, comparing the atrophy in the operated eye with macular buckle versus the contralateral eye. And I have verified that the buckle does not induce atrophy more than the natural history. These are just some examples. You see, after 10 years on the left, the operated eye with the macular buckle does not have atrophy. And this is another example again. So this was published. The macular buckle does not induce choroidal atrophy. And I want to conclude with my best case. This was a young male, 54 years of age, 32.8 axial length, 21 diopters of myopia. He had a macular detachment. I operated him with macular buckle, and on the right, you can see the result 3 years after surgery. I have done phaco with the multifocal IOL. He can see 20/20 far and near unaided. So this is to remind you that these are patients that can see if they are treated well. Thank you.
Oh, Barbara, it's a great presentation. Thank you very much for it. I think that you is a main expert in this field, in field of macular attractional maculopathy. And in your hand, it looks great, amazing. Thank you very much.
But it is, Grace. I want to give you all my enthusiasm, and I hope you will try to.
I hope that we will do it in future. Only one question. What about certification of your buckle? You told me before that you now... Yeah.
At the moment, you can buy this buckle, but is as a custom-made product. So you order one for one axial length, unfortunately, and it takes a few weeks. And we are starting this year, hopefully, the trial to obtain the CE mark and the FDA, hopefully, and this will speed up the process of manufacturing.
Great. So hope we see each other very soon in future Congress, and invite you next year, be in person in Ukraine. Thank you very much.
Thank you. Thank you so much. Thank you. Have a great meeting.
Bye-bye. Thank you. Bye.
Okay, and we continue. Nice to see you, dear Angie. We can see you, we can hear you, and we invite you for your presentation. Topic is, do we still need antibiotic eye drops after cataract surgery?
Dear chairs, dear colleagues, great pleasure to be with you again. Hopefully in the nearest future in person, not only virtually online. Here are my financial disclosures. None of them is relevant to the topic of this presentation, but I would like to disclose some sources of my presentation. One of the sources is our textbook that we published already, as you see, 2 years ago, but it's still up to date, with the colleagues from US, from Bascom Palmer and Professor Litvinchuk, Ukrainian head of the Department of Ophthalmology in Gießen, probably well known in the Ukraine, a good colleague. Again, another interesting source of the information, it's our article from Progress in Retinal Eye Research, already published 2 years ago, with the international group of experts led by Professor Tara Prasad Das from LV Prasad Institute in India. So let me start with some epidemiology data. As you see, I wanted to show you the, let's say, prevalence of endophthalmitis based on different studies. And as you see it in the red color, Of course, it depends on the different places of the world, different centers, but this prevalence is between 0.08%, so relatively low or very low, to nearly 7%, which is relatively, it is very high. So we still need to remember how to prevent against endophthalmitis, because at least in many places it is still a common problem. So what are the sources of infection? Just to repeat well-known information, it's mostly patients' own ocular surface flora. Up to 80% of bacterial isolates come from patients' ocular surface. That's why it's so important to diagnose before surgery cases of infections, including blepharitis or nasolacrimal obstruction. Another source might be contamination of surgical instruments. A very important, crucial issue is the non-complicated surgery. So any surgical complication raises the risk of endophthalmitis. For example, posterior capsular rupture with vitreous loss can increase it tenfold or even more. Finally, which is probably not as well remembered, poor or delayed wound healing is crucial. The structure of surgical wound is very important to the self-sealing process. And there was a very interesting study already published 20 years ago in Journal of Cataract Refractive Surgery, as you see, based on 15,000 of the surgeries. And they found that the single biggest relative risk for endophthalmitis was a leaking wound on the first post-operative day. And they found that the risk went up to over 40 times. So it's much more than any antibiotic can give us in terms of the protection against endophthalmitis. So the conclusion, the single most important thing we do to prevent endophthalmitis as a surgeon is to make sure that our incision will not leak. This is a very important message. So topics to be discussed regarding antibiotics: the present role of intracameral antibiotics, mostly cefuroxime and moxifloxacin, the role of topical antibiotics, especially when intracameral antibiotics are used, and then the role of antiseptics as an alternative for topical antibiotics. So the first message in this part is that intracameral antibiotics, including cefuroxime and moxifloxacin, are safe and effective, and this is based on over 15 years of evidence accumulation. And this is based, as you see, on the ECRS study, many later small retrospective studies, a few big retrospective studies, including Swedish study, French study, Aravind Eye Hospital studies, and finally the data from the Swedish Cataract National Register. So let me just remind the results of the ECRS study as we see it on the right side. This study was published in 2007, so again, nearly 20 years ago. And this study found that the use of intracameral injection of cefuroxime gave around 5 times protection against endophthalmitis. This study was then supported by many, as I mentioned, smaller retrospective studies. Here we see the studies that were conducted in Europe in this table. So as we see, Spain, UK, France, Sweden, Portugal, Ireland, Sweden again, and France, all of them showing some degree of protection between 3 to 5 times. Then appeared, well, a few and then more studies based on moxifloxacin. As we said, you can see here, this is one of the first studies based on moxifloxacin from Aravind Eye Hospitals from India, showing the 6-fold protection for phacoemulsification when intracameral moxifloxacin was used. And this study was based, as you see, on 600 of thousands of surgeries. But then later they published another study based on protection from the topical antibiotics against endophthalmitis rate. Another strong argument is the data coming from the Swedish studies and mostly Swedish National Cataract Register. Sweden is one of the few countries worldwide having such a national register. They evidence every cataract surgery with every endophthalmitis case. This study that was published already over 10 years ago, as you see, and was based on nearly 500,000 of cataract surgeries, this study showed that short-term topical antibiotics given as add-on prophylaxis to the intracameral regimen before and after the operation did not confer a clear-cut benefit. They were not able to find any benefit when using topical antibiotics before or after, of course, or both, when intracameral antibiotics were used. And this accumulation of evidence led to some practical changes, and in some countries like Sweden, Denmark, topical antibiotics are not used anymore in the standard cataract surgery, of course, when intracameral antibiotics are used. This is the protocol from one of the hospitals in Sweden, Linköping University Hospital, based on St. Erik's Eye Hospital. And this protocol clearly says that no post-operative and preoperative topical antibiotics are used. The same is true for Denmark. You see this is in Danish language and the English translation is provided at the bottom. Topical antibiotics are not recommended after routine cataract surgery. The same is true for Norway also, so in other Scandinavian countries. In France, this is the protocol, the national guidelines in France. They do not recommend to use preoperative topical antibiotics. This is the guideline from Italy, again, not recommending the preoperative topical antibiotics. And here we see the information from ECRS guidelines for prevention treatment of endophthalmitis. And what we can find here, that there is no clear benefit have been established for the administration of antibiotic drops preoperatively, but that bacterial resistance may be induced and complete bacterial eradication on the ocular surface is not achieved. Finally, the information from cataract in the adult eye preferred practice pattern from American Academy of Ophthalmology. Again, they highlight the role of the intracameral antibiotic and the small benefit of topical post-operative antibiotic in this guidelines. And the third topic about the antiseptics, and I would like to recommend to increase the use of antiseptics, mostly probably povidone as an alternative for topical antibiotics. Povidone iodine was developed, as you see already, many years ago, over 80 years ago, and povidone iodine antisepsis is the only technique to reach category 2 evidence in reducing endophthalmitis rates. It exhibits potent bactericidal effect upon contact for 15 to 60 seconds and is microbiocidal against multi-drug resistant bacteria, candida species, viruses, acanthamoeba, as well as capable of destroying biofilms. So much broad activity than any antibiotic. And it's available worldwide, is inexpensive, and very important, absent of drug resistance. It was checked several times, and so far it was not found any resistance against povidone iodine. Povidone iodine can be also used, and this is probably the future, in the treatment, not only in the prevention. This is the study that showed that topical povidone iodine, 1.25%, so much lower concentration than we use in the cataract surgery, was equally effective as antibiotics for the treatment of bacterial keratitis. So this is probably also the future for conjunctivitis, keratitis cases. This also led to introducing several guidelines also in the retina field. This is the guideline prepared by EURETINA in already 2017. So again, nearly 10 years ago, we prepared, I led these guidelines. This was the update on intravitreal injections. And within this guidelines, we recommended not using perioperative antibiotics before or after intravitreal injections. And well, presently, I must say that in great majority, at least in Europe, countries, antibiotics are not used anymore before or after intravitreal injection, because there is no single study showing any benefit of using antibiotics, of course, in delivering any protection against endophthalmitis. So I would like to highlight that endophthalmitis prevention is more than antibiotics use. At first, it's a no background infection, the use of antiseptics, a good instrument sterilizations, no complications, and sealed wound not leaking. This is crucial. And just to highlight and present very recent, just published in February this year, online, the meta-analysis published in Acta Ophthalmologica on the use of post-operative topical antibiotics, cataract surgery. This comes from colleagues from Italy, and they concluded that intracameral antibiotics as a sole prophylactic measure may be sufficient, and the routine use of post-operative topical antibiotics could be unnecessary. Reducing the use of topical antibiotics may also help mitigate the risk of antimicrobial resistance. I completely agree with this statement. So as a take-home message, I would like to say, what are the practice patterns to prevent post-operative endophthalmitis? Preoperative use of povidone iodine, irrigation, not just delivering one drop, no topical antibiotics, good surgery, no complications, seal wound already mentioned. Intracameral antibiotics, of course, is very important. And post-operative topical antibiotics are not needed in standard cataract cases, but during the transition period, we should use them relatively shortly for 3 to 5 days in a high concentration, and do not taper them. We should not taper antibiotics. This is the best way to rise the antibiotic resistance. And I would like to conclude with the title of our article that was published nearly 10 years ago, More Antiseptics, Less Antibiotics, Whenever Possible. And I would like to invite you to our EVER Congress this year in October in Florence, very, very warmly. Thank you very much for your kind attention.
Thank you very much, dear Angie, for the very interesting presentation and so deep analysis of this very discussable question. We strongly agree with you about antiseptics and the importance of using of povidone iodate before the surgery. And what concentration do you recommend for the preoperative prophylaxis?
Well, all recommendations, I must say, are, I mean, ECRS and many national recommendations, also US, they say are the same. So 5% for conjunctival sac and 10% for skin. However, in the recent years, there were a few studies showing that lower concentration than 5%, as you might have noticed, I highlighted that 1.25%, but even lower, 0.6%, might be also very effective. So we still do not have so many studies on that, just a few, but I think that they are quite convincing. So probably then we need to use the povidone iodine a bit differently because we need to repeat delivering povidone iodine during the surgery. But still, I think that the future will be based also on lower concentrations of povidone iodine. But presently, well, we should finally follow the guidelines, 5%.
Thank you. And about pre-op antibiotic eye drops, we agree with you that it is not necessary. About post-op eye drops, the same situation with the after using of antibiotic drops after intravitreal injections. A few years ago, it was discussed on European conference, and about intracameral antibiotics. Do you have in Poland the registered antibiotic for the intracameral injection?
Yes, we have. I mean, the intracameral cefuroxime, the brand name is Aprocam, is CE marked. So this is available in all European Union countries, including Poland. So this is the first point. So this is available. On the other hand, I think that the all European Union countries in their guidelines, let's say, regarding cataract surgery and preventing endophthalmitis, they highlight the necessity of the use of intracameral antibiotics. So, for example, in Poland, it is obligatory to use intracameral antibiotic. On the other hand, there are some, let's say, weaknesses because European law says that if any drug, if the on-label drug is available, we should not use off-label drug. So as we know, there is an alternative for cefuroxime. It is moxifloxacin, and well, and it is I would say a strong alternative with some potential benefits. Maybe if it's better than cefuroxime, but according to this European Union law, we cannot use it because it's only available off-label. So there are some limitations also of this. Yeah. So
Thank you. Thank you so much. I hope the next time we will meet with you in our next year conference. Thank you.
Looking forward. Thank you. Thank you.
Bye.
Bye-bye.
Okay, and we finish our program, and I invite, я запрошую Сергія Володимировича.
Invite Sergey Volodymyrovich for dear colleagues, dear participants. Unfortunately, we finish our Filatov Memorial Lectures 2025. We conducted powerful 2 days of work, during which we conducted 30 official sessions. We have listened more than 160 reports, including reports from our foreign colleagues, from leading speakers. We are very pleased because more than 20 countries participated in our lectures. So we conducted 5 workshops, 5 meetings of different associations. of ophthalmological sphere, of course. And we get a great pleasure of communication with one another. I hope that you gain a new knowledge and you were able to share your own experience. You communicate with each other. You like each other. You were satisfied. Thank you very much for visiting our conference, for visiting Odessa. Thank you very much to our speakers, foreign speakers. It was a wonderful conference. I hope that next year we will be able to meet and to conduct our next meeting as well. A meeting with friends. First of all, I want to thank also to our defenders that we have this opportunity to conduct this conference. I want to thank our partners who support us and who have been supporting us during many years to conduct our conferences on high level. I want to thank our organizational committee for your efforts and organizational measures. Thank you very much all. I hope to meet you next year. Thank you.